Thank you, Chairman. Today, I will demonstrate how to treat multiple pulmonary arteriovenous malformations, PAVMs, using vascular plugs and coils. A 65-year-old female was referred to our center for incidentally discovered multiple PAVMs in both lungs. She had a history of lacunar infection and her initial O2 saturation was 85%. She had a total of 10 PAVMs with feeding artery diameters ranging from 62 mm to 2 mm. To access the pulmonary artery, I used an 8-branch vascular sheath, a 6-branch 80 cm shuttle introducer, and a 5-branch angled pigtail catheter. Initially, I performed a right pulmonary arteriography, which revealed multiple PAVMs. Selective angiography showed a largest feeding artery with a diameter of 6 mils. To minimize the risk of recanalization after embolization, I prefer to use an M-Platz vascular plug to occlude large diameter feeding arteries. For this case, I selected a 12 mm Type 2 vascular plug. Using a secure heparinized saline flush to prevent air embolism, the AVP2 was gently advanced. At the target site, the introducer should be slowly withdrawn. After unscrewing the plug, I moved to the region in the lower lobe. Using only an angled catheter, we were able to safely select the target feeding artery. The feeding artery had a diameter of approximately 5 mm, so I selected a 10 mm Type 2 vascular plug. A 6-branch introducer can be safely advanced along the 5F catheter. Prior to inserting the vascular plug, it is crucial to perform saline flushing with a rotating Y connector to prevent embolism during the procedure. Initially, the distal and middle lobes of the plug were deployed in the venous sac. I recaptured the plug and redeployed it slightly more proximally. Before unscrewing the plug, angiography can be performed using a 6-branch introducer to confirm the precise location of the plug. After that, I moved to the regions in the right upper lobe. Using the rotating technique with a 5-branch catheter, I advanced the catheter to reach the target nidus. For this region, I used an 8 mm Type 2 vascular plug. Based on my experience, a 200% oversizing of the plug is recommended when performing PAVM embolization using an M-Platz vascular plug. This is because the pulmonary artery has a thinner wall and lacks smooth muscle compared to systemic arteries. Next, I moved to the lower region and using a similar technique, deploying a 6 mm Type 2 vascular plug.
6mm 없으면 5mm 줘도 되고. 있습니다. K4 6mm 드릴까요? K4 6mm입니다.
After completing the embolization of the right lobe, I moved to the left lung. Following angiography, I selected the apical PAVM for treatment. For this lesion, I choose coil embolization due to the angulated course of the 5 French catheter. The maximal venous sac diameter was 7.3 mm, so I selected a 10 mm 30 cm 3D concerto coil for embolization of the venous sac. After deploying the flaming coil with 10 mm 3D coil, an additional 10 mm coil was inserted. Following the flaming, two more 8 mm 3D coils were used to achieve tight coil packing. The concerto microcoil is very soft. As you can see, the small feeding artery is now tightly packed. To complete the coiling of the feeding artery, I used one more 3 mm by 8 cm helical coil. Next, I moved to the lower PAVM in the left upper lobe. Due to the acute branching angle of the feeding artery, I decided to use microcoils for this lesion. After deploying a 10 mm 3D coil for flaming, the microcatheter became unstable, making it difficult to achieve tight coil packing in the venous sac. For this reason, to achieve tight packing of the feeding artery, I used one 8 mm 3D coil and two 3 m by 8 cm coils. I then advanced the microcatheter into the coil mass and finally inserted a 2 mm by 8 cm coil for complete occlusion. Angiography confirmed complete occlusion of the PAVM. Following that, a lateral lesion of the left upper lobe was treated using a 8 mm Type 2 empalature vascular plug in the same manner. Due to the limitation on total contrast uses, I concluded the procedure. 2 days later, I performed an additional procedure to treat the remaining 3 PAVMs. One lesion was treated with venous sac coiling, while the other two were treated using Type 2 vascular plugs. The patient was discharged 1 day after the procedure without any adverse events. Her SpO2 increased from 85% to 99%. She is scheduled to visit my outpatient clinic in 6 months for a follow-up with a non-enhanced chest CT. Thank you for your attention.